Hello, I'm Dr. Ken Landau. Thanks for watching. Let's talk about shingles. Shingles or herpes zoster, caused by the varicella zoster virus, the same virus that causes chickenpox. It's reactivation of the chickenpox, actually. 99.5% of us have the chickenpox virus inside our bodies either because we got chickenpox when we were younger or because we were vaccinated against the chickenpox when we were children. Now, anyone who's had the natural infection or the vaccine has the virus inside the body. It lingers there for the rest of our lives, typically harmlessly until it causes shingles, typically just once. The Centers for Disease and Control suggests that about a third of us over the course of a lifetime are going to develop shingles. That means about 1 million cases a year. More common as we grow older, half of the cases being in people over age 60. Now, if you've never had contact with the natural infection, never been vaccinated, and you're around somebody with either chickenpox or shingles, could you catch shingles? No, you can't catch shingles. You can catch the chickenpox, but you can't catch the shingles from anyone. And once the virus is in your system, it's in your system forever. What causes it all of a sudden when you get to be 50 or 60 or 70 years old to grow as the shingles, we just don't know. But the rates are gradually increasing in the United States, which perplexes us because children who have been vaccinated seem to be less likely to develop as adults the shingles than people who were infected with the virus naturally when they were kids. Well, the term shingles comes from the Latin singulus, and that means girdle. It's a virus that affects humans only. There are no animal reservoirs. You can't catch it from your pet, can't give it to your cat or dog. It belongs to the same family as the herpes virus, the cold sore virus, the genital herpes virus, the mononucleosis virus, a virus that causes problems in people with HIV infection called Kaposi sarcoma. Lifetime risk, if you listen to the television, they say on some of the ads that it might be as high as 50%, but that's if you live to over age 85. Overall, the likelihood of your being infected somewhere, as I say, between maybe 20% or 30%, and the risk actually is smaller because as more people grow into adulthood who have received the vaccine that only became routine after 1995, then those people seem to be less susceptible to developing the shingles. Now, in children, shingles is a relatively uncommon disease. It seems to be especially uncommon in areas where children are given the varicella vaccine. The varicella vaccine is a live virus vaccine. It causes the latency of the virus, and it uses a strain of the chickenpox called the Oka strain from Japan. It lingers in the body and years later can come back just like the natural chickenpox. The incidence overall, if we look at 1,000 people, we're going to find 4 individuals who develop shingles over the course of a lifetime, over the course of a year. If we look at people over age 60, another 1,000 people, it's going to be increased to about 10. The risk is increased in people over age 50, and it really goes up in people over age 60, or if people have some kind of immunosuppressive disease, leukemia, lymphoma, they're on cancer chemotherapy, they're taking cortisone maybe for asthma or lung disease or rheumatoid arthritis, they have some sort of an autoimmune disease, maybe like lupus or a chronic disease or AIDS, or they're transplant recipients receiving some of those medicines to keep the immune system in check. Typically, you only get one attack of the shingles in the course of a lifetime. A very, very small number can have 2 infections, 2 recurrences, and sometimes, extraordinarily rare, 3 infections. I've actually never seen more than 1. Sometimes, unfortunately, the reports suggest that the rate of recurrences might be as high as 6%. I haven't the slightest idea where they're getting that kind of information. Now, people regularly mistake recurrent herpes, recurrent zoster, recurrent shingles for herpes simplex. And sometimes the two can actually look alike. So about 99% of the people who think that they have recurrent attack of shingles actually have recurrent attacks of genital herpes, oftentimes on the buttocks or the lower back. They mistake the two. They can look an awful lot alike, and in fact, in some cases, instead of just getting those typical cold sores, the little round areas that look about the size of a quarter, well, you can get a zosteriform type of herpes simplex that sort of looks like the shingles, but if we were to culture the lesion, no, it would actually be the herpes simplex. It occurs more commonly in women than in men, and in African Americans, it's only about 25 to 50% the rate that it is in Caucasians. Now, once upon a time, it was thought that maybe the shingles was the initial presentation of some underlying cancer, but that's not correct. And remember, you can't spread the virus to somebody who is already immune. So if you have the zoster, you don't have to worry about your children, you don't have to worry about your grandchildren, you don't have to worry about your parents. If it occurs in a pregnant woman, well, if the pregnant lady develops chickenpox, that's serious. If the lady develops shingles, doesn't mean anything. Now, clinically, the major manifestation is a painful rash. It's on one side of the body or one side of the face. It's grouped blisters that occur in patchy areas of red. And the blisters keep coming on over a period of several days. Then they scab up over 7 to 10 days. And then they clear over a period of about 2 to 4 weeks. Before the rash develops, some people develop some kind of unusual symptoms. They tend to occur anywhere between 2 days and up to as long as 18 days before the manifestations on the skin begin. These occur in about 70 to 90% of the cases. And this prodrome starts with generalized symptoms that you can't really make anything of. You develop a headache or a little fever, some malaise, maybe some extra sensitivity to the light. And then 1 to 5 days before the rash begins, you can develop some more specific symptoms. You develop pain and itching and tingling around the site where the shingles will develop. Sometimes the pain is so severe that people think if it's on the abdomen that they have appendicitis or gallbladder disease. If it's on the chest, think you have a heart attack. If it's in the face, you think you have a dental abscess. Then when the rash appears, it first appears as patchy redness, and then in that area of redness over a period of 1 to 5 days, you start getting blisters. Originally, the blisters are clear. Later on, they become a little bit cloudy. Ultimately, they dry up, they ulcerate, they scab. They seem to last for a fair amount of time. As I say, they last for about a week or so. They're only on one side of the body. It can either be the right side, it can be the left side. Sometimes it goes completely from the back to the center on one side. It can act sort of like a belt, but oftentimes it's patchy. It's a little spot here, a little spot there, still again in that one, what we call dermatome. And when the eruption fades, ultimately, the skin can either return back to normal, or you can have slightly depressed scars at the area, or the skin might be a little bit lighter, a little bit darker. Most of the time when you get the shingles, it occurs on the chest, from the back to the chest. About half of the cases. Sometimes affects the face, may affect the neck and an arm, the lower back and the belly. Sometimes it can even involve the genital area and a leg. Now, the reactivation occurs in one nerve. We don't know exactly why that occurs, but it does occur just in one nerve. In the overwhelming majority of people, there can be a little sprinkling of virus outside that nerve, but that's okay. Now, when a person develops more than 20 areas, 20 blisters outside that major area, that's what we call disseminated herpes zoster. And the dissemination can be on either side of the body. It doesn't have to be on just one. And that tends to indicate some sort of underlying immune problem. Now, there's pain, and everyone talks about the pain associated with shingles, and there is a lot of pain. The pain can either come before the rash, as we mentioned, that's the prodrome, can come during the time and slightly after the rash. So any pain that a person develops over 30 days, or some people say 90 days after the skin eruption begins, that's the acute pain. But the post-herpetic neuralgia that everyone worries about, that by definition is pain that persists more than 90 days, more than 3 months, according to most people, after the shingles. Now, it's important to realize that the pain of the shingles is not the same thing as having the active shingles. That's a nerve problem. The shingles itself is a skin problem. The pain in younger individuals tends to be relatively modest, not too severe. In senior citizens, the pain is at its peak. It's terrible among those people over age 65 or 70, and if you happen to be in between young and old, then the pain is variable. The pain at the site of the attack, when you're having the attack, can make the skin hurt. It makes the skin feel itchy or burny or tingling, or it can feel like a sharp or a stabbing sensation. Sometimes it's pulsating or throbbing, and at times it's intermixed with severe lancinating pains, like somebody is poking you with a red-hot poker. And that pain can be precipitated by the slightest touch of clothing or even a light breeze on the skin. And interestingly, instead of pain, some people have itching or numbness or pins and needles sensation. People can actually lose the sensation in the area of skin, and that can persist or it can fade over a period of time. It seems with reactivation, it's those ganglion cells, the nerve cells, that become infected, and when they become infected, actively infected instead of having the latent virus there, then that causes the nerves to become inflamed, and when they become inflamed, the white blood cells get to the area, and the white blood cells get to the area, they damage the nerve, and it appears that the post-herpetic neuralgia is due to damaged nerves. Now, it's interesting to note that if we look at the likelihood of post-herpetic neuralgia in people who are relatively young, say less than age 40, it's pretty rare. In people who are, say, over age 60 to 70, thereabout, it's about 10-15%. Look at people who are over age 80, it's about 20%. But even in people who are senior citizens who do develop the post-herpetic neuralgia, it doesn't have to last for the rest of your life. It tends to go away in about 85% after a year or thereabout. The likelihood of the post-herpetic neuralgia seems to parallel the severity of the pain you have with the acute disease and the extent of the rash. And it's not just any pain, not any little discomfort that you have. It has to be post-herpetic neuralgia by definition. It's more than a score of 40 on what's known as the Likert scale, the Likert scale going from 0 to 100. So people can get a little mild distress. That's not post-herpetic neuralgia. Post-herpetic neuralgia is really severe pain. It can be a constant throbbing, aching, or burning pain, an intermittent stabbing or electric shock-like pain or lancinating pain. It can cause the skin to become hyperalgesic. In other words, painful stimuli seem to be more painful than expected, or allodynia, where you develop pain with touch that would not normally be thought of as being painful. And some people just find that the skin is very itchy. Now, there are a lot of theories of why this particular post-herpetic neuralgia developed, and we don't know what the answer is. But interestingly, it appears that in many people, the inflammation continues in the nerve, and now we're finding recently that blood cells that are floating around in the circulation can actually have the virus for up to 8 years after the infection, and this occurs just in people who have post-herpetic neuralgia, not in people who don't. Is there a complication of shingles other than the post-herpetic neuralgia? Yeah, in a very small percentage of people, 1, 2, 3, 4% of the people, especially people who have immunocompromise because of leukemia, lymphoma, HIV, some other kind of reason, those people are susceptible to some added problem. And as a matter of fact, about 100 people die because of the shingles each year. Those people tend to have immunosuppression. One of the common complications is meningoencephalitis, or meningitis, or meningitis and encephalitis. Typically it's mild, and as a matter of fact, it's the third most common cause of meningitis after the enterovirus and herpes simplex. Well, most people just develop a little headache and some mental status changes, maybe a little bit of a fever. Tends not to affect the substance of the brain, but it may, and that's what we call an encephalitis. And encephalitis is associated with an altered consciousness or personality, and sometimes focal neurologic signs and epileptic seizures. Other people develop Bell's palsy, of the facial nerve in the face, or Ramsay-Hunt syndrome where it affects the ear, or sometimes a person can develop a stroke within the first year after shingles. It appears that the incidence of stroke is slightly increased, especially if you happen to develop the shingles of the face. You can have a bacterial superinfection of the skin. Some people rarely develop hepatitis or pancreatitis, or they can have involvement of the enteric nerves. The eye may be involved in shingles, especially when the shingles is on the face, the upper portion of the forehead and the tip of the nose. Those people oftentimes have fever and headache. They have loss of vision, droopy eye, a conjunctivitis or reddening of the eye. They can develop keratitis or uveitis. They can develop damage to the optic nerve and to the retina, and they can actually go blind from the shingles. So if you develop shingles and it is involving the tip of the nose or the eye itself, eye doctor, there you go. Well, the virus itself is a circular, non-replicating virus that lives inside the nerve, inside the dorsal root ganglia, and unlike the herpes simplex, where it just sits there and doesn't do anything, it appears that the varicella zoster virus, the chickenpox virus or the shingles virus, inside the nerve is constantly replicating, and it's making certain kind of protein all the time. And it seems that that may well have something to do with the ability of it to affect the skin. Now, we have something called a contained reversion, and a contained reversion means that periodically we actually find the DNA inside the saliva, in the saliva. So no symptoms present, but it just seems that sometime there's contained, it means you don't have any kind of symptoms. We get these contained reversions where the virus comes to the surface, goes back, and we think that that might be what boosts the immunity, boosts your own immunity and to those people around you with whom you're intimate, because it seems that that's that re-exposure that keeps the virus suppressed. Why does the suppression ultimately fail in certain people? We just don't know. And when it's involved in the latency stage, there are lots of neurons inside the ganglion cells. Only about 2% of them are actually infected. Now, unlike the herpes simplex, shingles is a lot different. So it doesn't tend to recur like the cold sore virus. It's more common in elderly, and the herpes simplex is more common in younger individuals. We know that the shingles tends to be pretty painful, whereas the herpes simplex tends not to be very painful. The herpes simplex is just one little area as opposed to an entire dermatome. The herpes simplex is caused by the sun. The shingles is not caused by the sun. And the herpes zoster, the shingles, is associated with more central nervous system abnormalities. Now, if you look at the skin, sometimes it's hard to tell whether it's an insect bite, a drug eruption, or impetigo, or erysipelas, or a yeast infection, or a contact allergy, or that herpes simplex that might sort of look like the shingles, or infection with some other kind of a virus. Well, let's say you're infected. What do we do to treat you? We don't have all that much to treat the acute symptoms. Loose-fitting clothes, soak the lesions to help them dry, maybe some oatmeal baths, some calamine, some pain control with aspirin or acetaminophen. If it's less than 72 hours since the blister started to begin, maybe we can use some antiviral agent like acyclovir or Valtrex or Famvir. But unfortunately, most people don't get to the doctor when the lesions are starting. Don't get there till after 72 hours. And after 72 hours, the antivirals don't seem to work all that well. So we just use simple wound control. And whatever the wound control that your doctor suggests, that's probably okay. Some believe that if you take some oral steroids, cortisone, prednisone, that might decrease the likelihood of developing the post-herpetic neuralgia. It's not supported by evidence. Some people, and there is some evidence to suggest that taking amitriptyline, that's an old-fashioned tricyclic antidepressant, that might help prevent some of the post-herpetic neuralgia. That's considered appropriate in some circles. Well, if we talk about treating the post-herpetic neuralgia, if we can decrease the pain by about 30%, that's considered fantastic. Few fewer than 50% of the people are going to achieve this degree of success with our currently available therapies. We don't have great therapy for post-herpetic neuralgia, which is a good reason to get the vaccine. The vaccine, and you can prevent the shingles, hopefully. The symptomatic treatment for post-herpetic neuralgia is take aspirin or take acetaminophen. It just doesn't work. Some lidocaine topically or capsaicin, some of those patches you can get. Maybe some gabapentin or Lyrica, again, doesn't seem to work very well. The antidepressant family seems to give us the best hope, that medicine like the amitriptyline, but that's nowhere near a home run. Effexor and Cymbalta are used, but they don't work great. The opioids are very popular, but again, they don't work great, and they're now considered at best a third-line drug. Probably shouldn't be used. There's acupuncture, there are nerve blocks, all sorts of things, but unfortunately, we just don't have any great therapy. Well, what about the vaccine? Yes, as a child, you should get the chickenpox vaccine. As an adult, you could consider one of the two vaccines that are available. The original vaccine contains the same virus as is present in the chickenpox virus. It's just 14 times more virus. That's the Zoster Max. Zoster Max came on the market in 2006. Didn't really work all that well. Worked only for a very short period of time, originally given for people just over age 60. Then they reduced it to people over age 50. But remember, the shingles doesn't come on typically till after age 60. And it seems that the Zoster Max provides protection for only about 4 years. So that isn't so great. But now they have a new vaccine. Came on the market in 2018. It's called Shingles. Shingles is a much better vaccine. It contains no live virus. The problem with the Shingles is you need 2 injections, the initial one and then the second one 2 to 6 weeks later. It's fairly expensive. You can get it once you're over age 50, but you could also wait until you're over age 60 or 65, because that's when the shingles tends to become most common, and that's when the pain seems to be most severe. It seems that the Shingles works for a longer period of time and provides much better relief, much better ability not to allow that shingles virus to leave the nerve. So if you're considering the vaccine, Shingles is the way to go. Unfortunately, they're having horrible time keeping up with the supply, so that it seems like it's perennially on back order. Anyway, if you have questions about either of the vaccines, the Shingles or the Zoster Max, we have shows on that too. So anyway, subscribe and thanks for watching. I'm Dr. Ken Landau.